The characteristic electron microscopic findings are discrete, amorphous, electron-dense deposits on the epithelial side of the membrane, often having the appearance of humps, presumably representing the antigen-antibody complexes at the subepithelial cell surface. Subendothelial deposits are also commonly seen, typically early in the disease course, and mesangial and intramembranous deposits may be present. Clinical features. In the typical case, a young child abruptly develops malaise, fever, nausea, oliguria, and hematuria, smoky or cola-colored urine, 1 to 2 weeks after recovery from a sore throat. The patients have dysmorphic red cells or red cell casts in the urine, mild proteinuria, usually less than 1 gram per day, periorbital edema, and mild to moderate hypertension. In adults, the onset is more likely to be atypical, such as the sudden appearance of hypertension or edema, frequently with elevation of BUN. The glomerulonephritis is subclinical in some infected individual, and is discovered only on screening for microscopic hematuria carried out during epidemic outbreaks. Important laboratory findings include elevations of antistreptococcal antibody titers and a decline in the serum concentration of C3 and other components of the complement cascade. More than 95% of affected children eventually recover renal function with conservative therapy aimed at maintaining sodium and water balance. A small minority of children, perhaps less than 1%, do not improve, become severely oliguric, and develop a rapidly progressive form of glomerulonephritis, described later. Some of the remaining patients may undergo slow progression to chronic glomerulonephritis with or without recurrence of an active nephritic picture. Prolonged and persistent heavy proteinuria and abnormal GFR mark patients with an unfavorable prognosis. In adults, the disease is less benign. Although the overall prognosis in epidemics is good, in only about 60% of sporadic cases do the patients recover promptly. In the remainder, the glomerular lesions fail to resolve quickly, as manifested by persistent proteinuria, hematuria, and hypertension. In some of these patients, the lesions eventually clear, but others develop chronic glomerulonephritis or even RPGN. Crescentic, rapidly progressive, glomerulonephritis. RPGN is a clinical syndrome associated with severe glomerular injury, but it does not denote a specific etiology. It is characterized by relatively rapid and progressive loss of renal function associated with severe oliguria and signs of nephritic syndrome. If untreated, death from renal failure may occur within weeks to months. The most common histologic picture is the presence of crescents in most of the glomeruli, hence the name crescentic glomerulonephritis. As discussed earlier, these are produced predominantly by the proliferation of the epithelial cells lining the Bowman capsule and by the infiltration of monocytes and macrophages. Pathogenesis. Crescentic GN may be a manifestation of a number of different diseases, some restricted to the kidney and others systemic. Although no single mechanism can explain all cases, there is little doubt that in most cases the glomerular injury is immunologically mediated. A practical classification divides crescentic GN into 3 groups on the basis of immunologic findings, Table 20.6, which have been described as follows. Anti-GBM antibody-mediated disease, characterized by linear deposits of Ig and, in many cases, C3 in the GBM. In some of these patients, the anti-GBM antibodies cross-react with pulmonary alveolar basement membranes to produce the clinical picture of pulmonary hemorrhage associated with renal failure, Goodpasture syndrome. Plasmapheresis to remove the pathogenic circulating antibodies is usually part of the treatment, which also includes therapy to suppress the underlying immune response. The antigen common to the alveoli and GBM is a peptide within the non-collagenous portion of the alpha-3 chain of collagen type 4. What triggers the formation of these autoantibodies is unclear in most patients. Exposure to viruses or hydrocarbon solvents, found in paints and dyes, has been implicated in some patients, as have various drugs and cancers. There is a high prevalence of certain HLA alleles, e.g., HLA-DRB1, in affected patients, a finding consistent with the genetic predisposition to autoimmunity. Diseases caused by immune complex deposition, with granular deposits of antibodies and complement by immunofluorescence. Crescentic GN can be a complication of any of the immune complex nephritides, including post-infectious glomerulonephritis, lupus nephritis, IgA nephropathy, and Henoch-Schönlein purpura. These patients usually cannot be helped by plasmapheresis, and they require treatment for the underlying disease. Pauci immune crescentic GN, defined by the lack of detectable anti-GBM antibodies or immune complexes by immunofluorescence and electron microscopy. Most patients with this type of RPGN have circulating antineutrophil cytoplasmic,